We have very sensitive tests that can measure for minimal residual disease. The most widely used test involves flow cytometry. And what that means is that the cells are put through a machine where they're excited by laser light, and you can then, with very sensitive, what we call gating on the cells, you can detect one cell in 100,000 quite easily. Some people say that you can detect one cell in a million, but I agree that one cell in 100,000 cells is probably the limit, or one cell in 10,000 cells is the practical limit with this technology. So I would say it's fairly easy with many different what we call colors on the cells. We can detect at least 1 in 10,000 with pretty good assurance. Anything less than that, you have to really have some fine instrumentation to detect. So 1 in 10,000 is the limit for that technology, and maybe pushed to 1 in 100,000 with the appropriate instrumentation. There's another technique, which is to use next generation sequencing, where we actually sequence the genome. This can actually achieve a detection limit of 1 in a million. Another technique, which is to use allele specific primers, these can also detect one cell in a million. But there's some important exceptions in that sometimes the genetic sequence of the leukemic clone is such where you can't get down to that level of sensitivity. It may be only 1 in 100,000. So patients will vary depending on the genetic sequence in their leukemia with the sensitivity of that test. And the other problem that we have with that test is that you really do need the leukemic cells that were there prior to treatment. Because if you just have the blood sample of patients after treatment and you don't have the ability to look at the genetic sequence of the cells prior to treatment, then you cannot really use these techniques very well. So that takes a little bit of advanced planning. You have to kind of bank away your cells before treatment, and then it has to be compared, making these less attractive for many patients. And I think we still need to work out the ways to make that more feasible for many patients. So these techniques still are very good, and I think we're settling on a limit of 1 in 10,000 cells as being a cutoff. And in point of fact, even if we had a test that could detect one cell in a gazillion, a billion, for example, it gets to the problem of what I mentioned before, where you're reaching into that drawer of socks. Okay, so if I reached into the drawer and pulled out a handful of socks and looked at it, white socks, I can easily spot one red sock in 1,000 socks. But my hand only contains about maybe 50 socks, if you know what I'm saying. So the sensitivity of the test that I'm using cannot really be greater than the number of socks in my hand. And so therefore, our sensitivity then is governed by a limitation of sampling. So when we pull either blood from the vein or get cells from the marrow, we're only getting a finite number of cells, and that limit on the number of cells that we draw is like the handful of socks in our hand. And so we're kind of reaching a limit of close to 1 in, if we went down to 1 in a million, but we couldn't do 1 in, say, 100 billion sensitivity. But still, I think what it represents is a significant advance over just looking at it by a microscope. And particularly if you look at the bone marrow and find no evidence of residual disease in the bone marrow, that's an excellent outcome. And we have these criteria of response. For example, we have complete response and we have partial response. And what distinguishes a complete response from a partial response is that for a complete response, one has not to have any enlarged lymph nodes, and the spleen should be normal in size. But we're pretty strict about it. Namely, if your lymph node happens to be larger than 1.5 centimeters, which is only about 1/2 inch, then it's not considered a complete remission by the current standards. I think we're being a little bit too stringent, because you can have a lymph node that's enlarged from scarring, and that would keep you from being called a complete response if you look by, for example, a CT scan and find a lymph node that's a little over 1/2 inch in diameter. That's pretty small, but it would keep you from being called a complete response. And so an interesting study was done by the German CLL study group, where they took 2 large trials, and those trials were comparing the regimen of FC versus FCR, or comparing BR versus FCR. That involves quite a lot of patients, over 1,000 collectively, or at least close to 1,000. And what they did was they were assessing the response to treatment, whether they achieved a complete remission versus a partial remission. And in some of the patients, they were able to assess for complete responses and MRD testing. So it's a subgroup of all the patients. But what was noted in that study was quite striking, that patients who were able to have eradication of minimal residual disease, such that you couldn't detect it, did very well. And they seemed to not fare if you had a complete response versus a partial response. Those patients who achieved a partial response, if they had eradication of a minimal residual disease, they actually did almost as well as patients had a complete response. There's very little difference between those groups. And they did better than patients who had a complete response, who had detectable minimal residual disease. So it may sound great, I had a complete response to therapy, but if you go in and take a look at the fine print, namely whether you have a complete remission or not with minimal residual disease, finding no evidence of minimal residual disease is a very good thing, even if you achieve what might be considered a partial remission.